One day. Okay. Let's not be 2 weeks from tomorrow.
I didn't know that. So anyway, we're gonna start. Good. Thanks guys for coming. This is exciting. Today we'll talk about severe diastasis recti abdominis in a multiparous postpartum female. Multiparous meaning that she's had more than one pregnancy at this time. So she's actually on her third. And this is my patient. I thought this would just paint a better picture of the patient and help you guys. So I chose this patient to increase my personal knowledge of diastasis and explore relevant conditions since public health is my passion at this point. I wanted to research potential risk factors that are associated with diastasis and acquire skills in managing diastasis as it relates to pregnancy. So here's a brief overview of the presentation. So I'll start by talking a little bit about physiology and prevalence risk factors associated with diastasis. I'll take you through the patient's case and with lessons learned and clinical relevance. So what is diastasis? This can be defined in several ways in the literature. It is typically defined as a separation of the two rectus abdominis muscles anywhere along the linea alba. So while there's agreement that this is abnormal, there's no real consensus as to what the true interrecti distance should be for the average adult, and that's just the width of the linea alba. So what does this mean for PTs? Again, we focus more on function, we want optimal support, optimal force production, and pain-free activity for our patients. I want to point out here that this is also considered a cosmetic condition by most insurance carriers. So it's really important to advocate for our patients in this population. So just a brief overview of the anterior abdominal wall that can be affected by this condition. We have the muscles, connective tissue, and aponeuroses in the anterior portion. As we know, the abdominal wall has several important functions, specifically in posture, pelvic and trunk stability, and then also in supporting those the viscera of the abdomen. So an increase in this interrecti distance can put these functions in jeopardy and leaves those structures vulnerable to injury. Here's a cross-section view I thought was pretty helpful in understanding everything that's going on. So specifically for pregnant women, the hormonal changes will actually change the elasticity of the connective tissue, as well as put mechanical stresses on the ab wall to make room for baby. So bottom line is when the linea alba is compromised and that tissue stretches, other things are compromised. So reported prevalence of diastasis in pregnant women varies due to different cutoff points, different measurement methods, and then different muscle activation through testing options. However, Moto's research in 2015 actually measured diastasis at gestational week 35 through ultrasound and reported prevalence of 100%. So that's pretty important. It's that all women are affected by this if they're pregnant. Here's a list of potential risk factors that I pulled from various sources. Again, this is considering all populations that can be affected by diastasis. I've highlighted in blue all risk factors that my patient presented with. To date, there's no statistically significant differences in patients with diastasis and those without. But I still thought it was important to show what this patient exhibited. Okay, so what does this mean functionally? Research shows there's an increased prevalence of diastasis in patients with urinary incontinence, fecal incontinence, and younger support-related pelvic dysfunctions. And then again, lumbo-pelvic pain is also occurring there. So on to the initial eval. Just a little bit about my patient. She was 36 years old. We were at 7.5 weeks postpartum when physical therapy started. She presented to physical therapy with diastasis and noticeable organ protrusion with strenuous ADLs. She involved carrying and lifting her 4-year-old son, who's about 35 pounds, and then other household activities that she was doing at the time. However, she was pain-free, so I think that's important to address here as well. She specifically wanted to address the cosmetic component related to this diastasis. So she was currently breastfeeding, and research shows that certain hormones, they're unsure of which ones actually affect the connective tissue at this time, but certain hormones that increase the extensibility of that connective tissue can remain in the system as long as you're breastfeeding. So the question at hand is, how does that impact recovery, and does that prolong the process? So something to consider. For surgical history, this last pregnancy and delivery was a cesarean. And then she had, just prior to physical therapy, what's called a dilation of curettage. So sometimes after pregnancy, there's remnants that remain in the uterus and that need to be surgically removed. So that is something that she had to undergo. And again, at this time, she denied bowel bladder issues, medication use, and swimming. I also want to point out here just the patient's general demeanor. As you saw in the picture on the title slide, she had pretty extensive damage, significant ab distension, and so she was very upset with her appearance as a 36-year-old woman. So that played a major role in this case. More about this patient. She's a mother to 6-year-old, 4-year-old, and 2-month-old boys. She had a very inconsistent exercise routine throughout pregnancy, prior to pregnancy. She had a bout of physical therapy with my CI prior to her third to address diastasis from her second. Her husband's a certified strength and conditioning specialist, and so I used that to my advantage later on. I'll talk about that. And her plan was to return to her desk job in January. I gave my patient a few questions to answer about the second treatment session that we had, just because I wanted to learn more about the specifics regarding each pregnancy that she went through. And so there's a lot on this slide and in this chart, but I'll focus mainly on the third pregnancy since that's where we were. It was a cesarean. It was 12 hours of labor until the cesarean and 4 hours of unsuccessful pushing. I want to point out that this baby was the largest, and she's past that high-risk maternal age at this time. Okay, so on to my objective findings. We'll start with the infrasternal angle, which was 106 in supine. It's normal for this angle, and again, that's measured just from the xiphoid process to the bottom rib cage. It's measured, or it's normal for that to increase throughout pregnancy, again, to make room expand for a baby. But optimal should be about 90 degrees. If you consider the way that the external and internal oblique fibers run, should be, there's even pull, it should be 90 degrees there. In static hook line, diastasis was present, and I'll get to that in a couple of slides. She did demonstrate an ability to isolate bilateral transverse abdominis, minimal verbal cueing, and was unable to maintain more than 5 seconds at this time. Posture-related concerns here, we had forward head, rounded shoulders, and noted in standing and sitting, increased anterior pelvic tilt, and lumbar lordosis. Lumbar spine, hip, SI joint were cleared at this time for pain. So symmetrical movements with any of the lumbar spine assessments and things of that sort. And then her active straight leg raise at this time was positive for faulty load transfer on both sides. However, it was pain-free. So if you remember, the active straight leg raise helps and is effective for measuring the load transfer between your trunk and your lower limbs. So with those active straight leg raises, if you have optimal load transfer, your pelvis would not shift in any direction. So we did see that, just again, a global assessment of her movement there. And so here's my outcome measure that I've used throughout this case, measuring the interrectus distance by the palpation partial curl-up test. The gold standard for this measurement is actually the ultrasound, as I mentioned earlier. Another option would be the caliper. That's another non-invasive option. Research states that clinically this is sufficient for detecting diastasis palpation test. So that is what I decided to go ahead with. And what was available to me, the interrectus distance was measured 4.5 centimeters above the umbilicus, at the umbilicus, and 4.5 centimeters below the umbilicus. So we classified this patient based on her largest measurement between those three areas, which was at her umbilicus. So here we have pictures of that initial palpation testing. I want to note here that palpation testing has good intra-rater reliability, so between sessions with the same PT, that's what we decided to go with. Now, I palpated myself. I do want to point out that we used my CI's finger width measurements because she was going to continue with the patient after I was gone, after 6 weeks. So according to MODA's classification, this patient did present with severe diastasis with 5 finger widths at rest, 3.5 finger widths with her transverse abdominis contraction. There was no palpable tension in this area, which is another important component of this. So upon palpation, palpate the abdominal organs, the aortic artery, the aortic pulse was felt through here, and again, just not a good barrier in this area. So another thing to note. You can also see in the right-sided picture, her descended mid to lower abdominal wall and recessive anterior pelvic tail to lower lordosis. So diagnosis for this patient, diastasis recti abdominis with abdominal muscle weakness and poor lumbar-pelvic control contributing to those functional limitations, which consisted again of child care responsibilities and wanting to return to exercise routines that she was unable to do at this time. So research states that greatest recovery of diastasis occurs between day 1 and 8 weeks after delivery, and that without any intervention or core training of that nature, there was no further closure at the end of that year postpartum. In general, as we know, we've learned through this program that connective tissue takes a long time to heal, so that's something to consider. Breastfeeding also plays a role in this as well. So prognosis, I anticipated a transition to at least community-based fitness activities within 12 weeks with special precautions. I chose to be fairly aggressive with seeing this patient twice a week for 8 weeks with a taper to once a week due to work responsibilities and returning to work in January. This patient, it's important to keep in mind, was most likely going to be seen for a year, 6 months to a year at least, at which point some patients are appropriate for surgical repair. So, these were the goals that I specifically wrote out for this patient. My goal specifically, the patient will demonstrate palpable tension in less than 3 finger widths diastasis with the partial curl-up test within 4 weeks, indicating she had better motor recruitment, things of that nature. And for her specifically, she wanted to, again, return to yoga, Pilates, general strengthening programs, as well as be able to pick up her children without feeling unstable. So that, again, I anticipated within 12 weeks there. So at this time, I'll take just a few questions if anybody has them about the patient before we move on to plan care.
So you mentioned that her appearance was really important to her. Do you think that her husband's job in the fitness industry had any role in that?
I do. This gentleman, was in the gym every day, and that was very important to him, and so I think that did carry over. He was very supportive throughout the whole thing, but there was part of that, I believe.
Can you repeat the question?
Oh, yes, she's asking if her husband being in the fitness industry had an impact on this particular patient feeling kind of that worry, anxiety about this.
Can you explain again really quickly the insurance component of this and how?
Yeah, so it just in general, and just something I glanced over throughout research, is it's considered cosmetic. As far as if you're needing and requiring that surgical repair later on down the road, that's specifically what I was talking about with that one.
Were there any other comorbidities, any back pain, anything else that you could contribute to?
It did. It came up later as we were working out and going through treatment, but she did not come with a history of that, as far as I knew.
Yeah, repeat the question.
Yeah, sorry. Was there a prior history of pain? Okay. So on to plan of care and the interventions I chose. Each subsequent slide will focus on each box that I've listed here, but my plan was to promote co-contraction of transverse abdominis and those pelvic floor muscles, and be able to sustain that co-contraction throughout functional movements. Through patient education to improve self-awareness of her diastasis and for that to carry over to functional activities. I wanted to implement isometric contractions throughout the surrounding musculature, improve the load transfer with her single leg activities, potentially decrease the infrasternal angle that I mentioned, and again, progress to for community-based activities. And then last, promote symmetrical movements that kind of came about as we continued working together and counteract her breastfeeding posture that was occurring as we were working together. So as we know, posture can have a big role in diastasis and exacerbating that issue. I'll also point out here that I recommended an abdominal binder to be used. Let's talk about that just a little later. Okay, so research states that transverse abdominis is the most beneficial therapeutic target for women or for those with diastasis due to those strong fascial connections between transverse abdominis and rectus abdominis, specifically the linea alba. So focusing on transverse abdominis would allow for efficient load transference. So I chose to isolate local muscles, transverse abdominis, and pelvic floor muscles, then improve the endurance of transverse abdominis, promote synergistic activity through from the lumbopelvic musculature, deter compensation from those accessory muscles as she fatigued. So here's what her initial home exercise program consisted of. Again, isolating transverse abdominis in various positions. I chose sideline as it's more gravity neutral, and I felt she could do more repetitions in that position. And then, again, recruitment from those other muscles surrounding the area as well. So pelvic tilting, quadruped, bridging to include activation. So that's what we started with, and that's what we progressed throughout the 6 weeks. I wanted to point out there, the home exercise plan program was a major component. She was very compliant, very motivated to do this, so I could throw really anything at her, and she was willing to do that. She had time away from work, and so that really helped us. This is a thing that she needs to focus on a daily basis. So. Patient education, self-checking diastasis throughout her exercises, observing and palpating for actual protrusion of those abdominal contents, emphasizing the importance of creating that tension that I talked about through linea alba. Her husband has attended a session with us to practice palpation and help her through her exercises, cueing on the floor. And I just take advantage of that, and he's really willing to help. And we use the abdominal binder while she was at home with strenuous ABLs and there. I used it mainly as a reminder for her to help with her receptive feedback. Again, we had special precautions that we just discussed throughout treatment. So proper lifting techniques, bracing for coughing and sneezing, avoiding activities of the straight leg raises, crunches, sit-ups, things of that nature. So throughout treatment, patient would mention various aches and pains. She reported discomfort in the mid-back after breastfeeding, discomfort in the low buttock region, standing activities, single leg activities, climbing stairs, things of that nature. So I related them to childcare responsibilities and lack of support and stability that she had at that time. So here's just a list of my objective findings throughout treatment. This occurred 2 to 3 weeks into our treatment. So just the nagging aches and pains that she was having. I do want to point out here, we did over time see improvements of the affected tissues as we started to address those. Again, the strength component is going to be an ongoing process, but okay. So I had several goals in mind with these exercises. Main thing was for support and stability. We want to consider that optimal form closure, force closure, motor control. We're focusing on the lumbo-pelvic hip complex. I focused on neuromyofascial stability throughout this treatment. So again, like I mentioned, specific muscle activation, strength, endurance of these muscles, both local and global stabilizers. And so these are the exercises I chose to recreate those more functional activities for her. So I did focus on the targeted muscles that are listed above, based on the previous slide. But again, the main focus, the main point that I was trying to accomplish was can we maintain the transverse abdominis contraction as we progress the upper body and lower body exercises. Point out here, there's no standardization for transverse abdominis exercises to date. So I really used my clinical judgment and used the Pilates reformer that you can see up here. She felt comfortable with that, and so she really enjoyed it. So throughout treatment, there was organ protrusion as I progressed exercises, maybe a little bit too quickly. So I was consistently assessing for diastasis, for bulging, organ protrusion, width and the tension. That was an ongoing thing for each exercise when we do that. So that was a good indicator that it was just a little bit too much and we needed to back off. Last was the soft tissue work and stretching, again to promote optimal movement patterns and posture. As we know, this has a great effect on diastasis. And so here is her reevaluation palpation testing the last week that I was at Progress. At this time, the patient demonstrated a negative active straight leg raise bilaterally. She improved her load transfer. There were no significant changes in the infrasternal angle at this time. However, improved awareness of her posture, improved single leg stance, improved ability to maintain the transverse abdominis contraction. So she was really able to hold 40 seconds at a time without much concern there. Finger width at rest was 5, but we did get down with the TA contraction to 2 finger widths. So functionally, what did this mean for her? Again, this just goes off of subjective information that we got here. She felt more stable throughout her activities at home, felt like she could pick up her child and didn't get that organ protrusion that she was experiencing before. So now my CI has continued to work with this patient. So here we are, month 4, which is about March timeframe. Research shows strength exercises for rectus abdominis should be implemented at this time. Okay. Should be implemented at this time and after diastasis is reduced to 2 finger widths. So that was their main focus. You can see here with the transverse abdominis and rectus abdominis contraction, we're down to 1 finger width. Okay. So I'll go back. I'll point out here, as you can see, it's stayed at 5 finger widths rest. So will that ever return? There's new research out there now that focuses more on creating tension throughout linea alba and not so much focusing on the width. It actually shows that transverse abdominis work can widen the interrectus distance, but I just think that's important for everybody to know here is that most likely will not return to your functional less than 2 finger widths. So lessons I learned, this was very emotionally taxing for my patient. She didn't care about my palpation testing. She cared more about how her stomach looked and that it was continuing to look the way that she did not prefer. So this played a major role in her recovery, I believe. I didn't realize initially that a continued presence of those hormones would play such a great role in her recovery. Again, there's conflicting research on that at this point, but something to consider. Oh, sorry. I should have used more functional outcomes, and so I recognize that as a limitation for myself. Again, we just used the palpation testing and should have checked lifting, mechanics, and things like that specifically to compare over time. And then research limitations. The research is out there, but it varies significantly with parity, different exercises that they choose, and so that I found that challenging to this case. So my clinical pearl and what I want you guys to focus on is that you will see pregnant women. As I mentioned, there's a prevalence of 100%. This can be seen in any setting, in men and women. So I think that's really important for all of us to consider. Any questions?
Yeah, I have 2 questions. Did she keep breastfeeding throughout her entire plan of care?
And she was with me, yes. Yeah, and I don't know at this time if she's still doing that. So it's month 4. That was a good question. Yeah. I'm not sure if in March she was still doing that, but I would assume so, based on how much she was breastfeeding through others.
And then did you ever find that she had difficulty isolating the transversus abdominis? And if you did, what verbal or tactile cues would you give?
I'm sorry. Yeah, did she have any difficulty isolating transverse abdominis contractions? No, because she was an avid Pilates participant, and she had also had the UPT with my CI before, so that was not a big concern for us. But the cues that we learned in class, 20-30% effort. I think I had it on the slides. 20-30% effort, as if you're huffing. It should just be a deep tension, inch in and below your ASIS. Point as a patient, she, did surgical fixing. So, at what point would she become a candidate for operation? There is a great article from Lee that has 5 or so indications for when that's warranted. They want you to try multimodal treatment for a year before considering that at all. The active straight leg raise is in there and some other testing that would help guide you. Trying this for a year
discover whether or not there's co-prevalence with back pain in seniors? We did some research. Was there any?
Yep, so co-prevalence with low back pain. What they're saying now is that they're not necessarily related. And I haven't delved too deep.
So you know kind of why I'm asking this, because you know the trunk is, I mean, it functions as a unit, I guess. And,
Right.
you know, I'm concerned that there was a Larry deficit somewhere with that problems with knees and brows. I know a woman that had this experience who had pretty terrific back pain, relevant experience, and she had a repair. Back pain went away.
Right. There is evidence of that. There's also evidence that it's not necessarily the diastasis that's affecting that. They just kind of coexist sometimes. So this particular patient didn't have true back pain. So, but that is out there. Yeah.
I'm just trying to think of a way to get surgery covered by insurance.
Right.
You know, demonstration of back pain, perhaps, you know, there's a link between the two. Yeah.
I was asking that because of the older people, I felt like they